All right. Good morning, everyone. Thanks for joining us in this morning's Skills Builder session titled Abortion in the United States, the Current Landscape and Its Implications. For those that don't know, my name is Reagan Johnson, and I am the Women's Health Manager at CityMatch. My pronouns are she, her, hers, and I am coming to you today from Omaha, Nebraska, which is on the lands of the Omaha and Sioux people. And I will be the moderator for today's session. So I'm really excited for today's session. I always try to bring at least one session around abortion to our conference, especially in the MCH field. It's a topic that sometimes can be a little bit neglected. So I love to bring this content to our conference attendees and our members. So before we dive into today's excellent presentations on this very important and timely topic of abortion, I am going to ask each of our presenters today to give a brief introduction of themselves. And of course, you can find more detailed information about today's session and today's speakers in the conference platform. You'll find their headshots and a more detailed bio for them. So we are going to go ahead and start with our two presenters from the National Institute for Reproductive Health. So I will turn it over to them now for their intros.
Hi, everyone. My name is Anjali Salvador. I use she, her pronouns. I'm a policy counsel at the National Institute for Reproductive Health, and I'm based in Houston, Texas.
Hi, everyone. My name is Arpita Appannagari. I'm the Policy and Partnerships Manager at the National Institute for Reproductive Health. My pronouns are she and her, and I'm in Brooklyn.
Perfect. Kari, I'll turn it over to you next.
Hi, I'm Kari White. I am on the faculty at the University of Texas at Austin in the Schools of Social Work and Department of Sociology. And I lead research on access to contraception and abortion in Texas and several states in the Deep South.
And then Diana, next to you.
Hi, my name is Diana Greene Foster. I'm a professor at the University of California, San Francisco, where I led the Turnaway Study, which I will talk more about. Thank you.
Awesome, thank you. And I am so grateful for all of our speakers. This session was truly a late-breaking session, and all of these speakers agreed to present and share their time and expertise with us with like a 2-week turnaround. So very, very grateful to have all of them here today. As a quick note, we will have 3 sets of presentations today. We have our partners from NIRH, we'll have Kari, and then we'll have Diana present. Kari does have to leave early, so after Kari's presentation, we will open up for Q&A for her presentation. But for the other presentations today, we will save those questions until the very end of the session. So feel free throughout to type in any questions you have. I'd be grateful if you could note who your question is for. That kind of helps me moderate the Q&A portion, but I will go ahead and turn it over to our wonderful colleagues from NIRH to kick us off today. Thank you so much.
Okay, can folks see my screen? Great. So like I said, I'm Anjali Salvador. I'm at the National Institute for Reproductive Health. NIRH works with state and local organizations to advance proactive policies in reproductive health, rights, and justice. And I'm going to start off by talking a little bit about the legal policy landscape here in the United States. See if my slides work. Here we go. So even though I'm here to talk about policy, I always like to lead with this. It's really easy to get caught up in political rhetoric, but before we do any of that, I want to frame this in terms of people. And the fact is that a lot of people have abortions. In fact, nearly 1 in 4 American women have an abortion by age 45. I know that when I talk to people who are unfamiliar with this work, many of them are surprised by some of the stats on this slide. For example, that a majority of women who have abortions already have children, or that they identify with a religion. And then there's a couple of other things I want to note just for scene setting purposes. First of all, that abortion is incredibly safe. Studies have shown that abortion is 14 times safer than carrying a pregnancy to term. And then another thing I want to mention is that while we'll be talking about abortions at various stages of pregnancy, close to 90% of abortions take place in the first 12 weeks. And then finally, you've been hearing me talk about women. I do want to acknowledge that there are trans and non-binary people who need abortions too. Unfortunately, the fact is that we just don't have as much data that's specific to those communities, but I want to make sure I say explicitly that abortion is not only an issue that affects cisgender women. So with that kind of scene setting, I'll move to the Supreme Court. So everyone's heard of Roe v. Wade, a 1973 case that says that access to abortion is a fundamental right guaranteed by the Constitution. Another important case that you've probably heard more about in the news lately is Planned Parenthood versus Casey from 1992. It created the framework that courts use to analyze state government restrictions on abortion access. So Planned Parenthood versus Casey says that there's a right to abortion until viability. That's the point when a fetus can survive outside the womb. However, Casey also says that states can restrict the right to access abortion even before viability, as long as those restrictions don't place an undue burden on the right.
Oh, sorry to interrupt real quick. This is Reagan from City Match. There is a small little box on your presentation. It's covering a little bit of it. Perfect. Thank you.
Great. So technically, the undue burden and viability framework is still the framework that we're using, at least for the time being. However, the interaction between the application of that framework and the evolution of state policy has changed a lot in the last decade or so. And there's a lot of reasons for that. Unfortunately, between Casey and now, courts have become more and more likely to uphold state restrictions on abortion even prior to viability. In the last decade, various states have passed over 400 laws restricting access to abortion. These restrictions can look a lot of different ways. They can look like TRAP laws, which stand for targeted restrictions of abortion providers. Those are things like saying that people who provide abortions have to have admitting privileges at hospitals, or that abortion facilities have to meet the standards of ambulatory surgical centers, even though oftentimes those restrictions aren't medically necessary. These restrictions can look like gestational bans, which are the 6-week bans you've probably heard about, sometimes referred to as heartbeat bans, or the 15-week ban that was recently considered by the Supreme Court, which I'll talk a little bit more about later. They can also be reason-based bans, such as bans that say that abortions can't be provided if people are getting them because the fetus has Down syndrome. So these are things that appropriate the language of disability advocacy to police the reasons why people might want abortion. And you can see from this graphic that in 2020, 29 states demonstrated hostility to abortion rights, a much larger number than the states who demonstrated support. Of course, even though a lot of bad things have happened over the last several years, a bunch of good things have happened too. Many states have taken steps to protect the right to access abortion, or to make abortion care more accessible in practice by removing cost or logistical barriers. This year in particular, some notable developments include that Delaware and New Mexico have removed some pre-Roe v. Wade language from their state laws that criminalized abortion. Even though those provisions hadn't been enforced for decades, removing them guarantees that they can't be used to threaten abortion providers or their patients if abortion rights are further weakened or overturned. Additionally, Illinois repealed its parental involvement law, which will make things easier for minors who need to access abortion care. And if you're wondering about any disconnects between this map and the previous one, the previous map only tracked hostility to abortion, whereas this one is tracking proactive legislation for reproductive health, rights, and justice generally. It includes proactive abortion legislation, but also things like increased access to contraception, legislation to decrease maternal mortality, and paid family leave. NIRH puts out multiple reports every year detailing proactive legislation. Our end of year report is going to be published on hopefully next week on December 15th. I'd like to touch briefly on the policy landscape at the local level too. On the negative side, we've seen increasing numbers of anti-abortion ordinances which purport to ban abortion within municipalities. These are not constitutional since the right to access abortion still exists, but they're difficult to challenge because they explicitly state that they won't be enforced unless Roe v. Wade is overturned. However, they're still dangerous. They confuse people about what their rights are and deter them from seeking out care. Community response to these ordinances has been varied. They've been successfully defeated in several places, but many of them have also passed, particularly in small towns where anti-abortion activists turn out evangelical communities. And then on the proactive side, a lot can happen there too. Multiple cities have implemented funding to help people pay for abortion care, and several are exploring using some of their ARPA funding to do so. Protecting patients and staff entering clinics from harassment continues to be an ongoing need. Cities can address that using things like buffer zones or even existing noise ordinances. Proclamations on Abortion Provider Appreciation Day on March 10th have passed in several cities. And then some cities are also exploring the creation of commissions or task forces focused on reproductive justice that can advise local government. When talking about proactive policy, though, it's important to note that we've also seen red states passing or attempting to pass laws that prevent municipalities from implementing these proactive policies. So that's something to be aware of. Then I won't go into detail about this, but this graphic is part of NIRH's biennial Local Reproductive Freedom Index. It evaluates 50 cities and counties on 34 different indicators related to reproductive health, rights, and justice. That index describes a model city, which is our framework for a city using all the tools at its disposal to support the freedom and ability of each person to control their sexual and reproductive lives. So the URL at the bottom of the slide has more info on that if you want to learn more. So against the evolving backdrop of this state and local policy, the situation at the Supreme Court has been evolving. In 2016, there was a good decision in Whole Woman's Health versus Hellerstedt. That case held that 2 Texas restrictions on abortion were unconstitutional. These restrictions are trap laws of the kind that I described earlier. The first one required that abortion providers have admitting privileges at a local hospital. The second one required that abortion facilities meet the same standards as ambulatory surgical centers. However, as I said before, abortion is an incredibly safe procedure. You're much more likely to die from childbirth than from having an abortion, and these regulations weren't medically necessary. Implementing them resulted in the closure of the majority of clinics in the state. The Supreme Court ruled that these regulations were unconstitutional using the undue burden standard that I talked about earlier. They said that the undue burden analysis has to include looking at whether laws are actually beneficial to women seeking abortions, and what the practical consequences of implementing them would be. I go into detail about that because the Supreme Court considered virtually identical regulations out of Louisiana in June Medical versus Russo last year. But between those 2 cases, Justices Gorsuch and Kavanaugh were added to the court. Like the Texas restrictions, the Louisiana ones were struck down. But it was a 5-4 decision, and in joining the majority, Chief Justice Roberts made it clear that his vote went that way solely because he didn't feel comfortable walking back a decision that was just 4 years old, not because he actually disagreed with the restrictions. And his analysis walked back a lot of the broadening of that undue burden framework that had happened in Whole Woman's Health versus Hellerstedt. Now, between June Medical and now, Justice Amy Coney Barrett has joined the court. As the makeup of the court has changed, we've seen increasing numbers of conservative states pass unconstitutional abortion bans on purpose in the hopes of teeing up a case the Supreme Court can use to gut or overturn Roe v. Wade. So just over a week ago, the Supreme Court heard oral argument in Dobbs versus Jackson Women's Health Organization, a case out of Mississippi. In 2018, Mississippi passed an abortion ban that's blatantly unconstitutional under the Roe and Casey framework. It would prevent abortion prior to viability at 15 weeks. There's basically no way for the Supreme Court to uphold the law that would not overturn the core principle that states can't ban abortion prior to viability. Mississippi was not the first state to pass a pre-viability abortion ban, but it is the first state that reached this, the first case that reached the Supreme Court. Unlike in June Medical, in which most of the oral arguments were framed in terms of the existing constitutional framework, in Jackson Women's Health, the arguments were about whether the constitutional right should exist at all. While we won't get a decision until sometime next spring or summer, from the questions the justices asked, it seems likely that the right to access abortion will be at best weakened and potentially overturned. So you might be wondering in all of this why I haven't talked about Texas. Others on the panel are going to talk more about how anti-abortion policies play out on the ground, but before I pass it over, I'd like to frame up some of the legal background. So backing up a little bit, Texas's SB 8 is a 6-week ban. Several states have passed these bans in the past few years, but what makes Texas different is that unlike bans in other states, which are enforced by state officials, SB 8 gives the general public unprecedented authority to enforce the ban. It allows anyone, including out-of-state anti-abortion activists, to act as bounty hunters and take providers and people who help others access abortions to court. It's explicitly designed to put abortion providers out of business. The idea is that they won't be able to defend themselves against an onslaught of lawsuits. And it's also explicitly designed to get around court review. Every other 6-week ban has been blocked by the courts before going into effect. And the reason for that is that abortion providers have been able to sue the state to block the law. Here, the bounty hunter provision is designed to help the state make the argument that they can't be sued because they're not the ones actually enforcing the law. There's a lot of nuance and legal specificity to this, but functionally what's been happening is that the parties to the case, which now includes the federal government, have been arguing about who the proper plaintiffs and defendants are and the way that the case should be framed, not whether the law itself is actually constitutional. And unfortunately, the Fifth Circuit Court of Appeals and then the Supreme Court made the unprecedented move of allowing the law to go into effect while the procedural questions get sorted out. This has all been very in the legal weeds, but I think the broader theme here is that the courts are not going to protect abortion rights, especially since Donald Trump appointed over 200 federal judges, including multiple Supreme Court justices. And since Texas is the second most populous state in the nation, the actual impact of all of this has been devastating. So with that, I'm going to pass it over to Dr. Kari White, who will talk more about impact. Thank you.
Great, thanks so much, Anjali, for that intro. I'm going to work on my screen share here. All right, can you all see this?
That looks great.
Great, thank you. So I'm going to talk about some of the research that my colleagues and I have been doing about access to abortion in these two states that are really ground zero and legal challenges around abortion in the United States right now, Mississippi and Texas, as Anjali nicely set up here. So I'm first going to talk about some of the research that we have been doing in Mississippi. And just by way of background, I think as a lot of folks already know, and as seen in Anjali's slides, Mississippi is one of the states that is considered very hostile to abortion rights. It has one licensed facility providing abortion, Jackson Women's Health Organization, which is the pink dot there in the south central area of the state. And Mississippi has numerous restrictions related to abortion that make it difficult for people to access care and access care early in pregnancy. This includes in-person state-directed counseling that's required at least 24 hours before an abortion, restrictions on the use of telemedicine, bans on insurance coverage in both commercial plans as well as Medicaid, parental consent for minors, ban on the use of dilation and evacuation, which is the standard procedure for second trimester abortion and the later part of second trimester, amongst many other restrictions. And as you can see in this map by the dashed circles, which represent a 50-mile radius around facilities, most counties in Mississippi are well over 50 miles from a facility either in state or out of state. So that exacerbates, these distance barriers are exacerbated by the many other restrictions, such as bans on the use of telemedicine. Additionally, the states surrounding Mississippi also have numerous restrictions on abortion, including mandatory waiting periods, all of which require first an in-person consultation visit. These waiting periods range from 24 hours in Louisiana to 72 hours in Arkansas. And this forces people obtaining abortion care at these locations to oftentimes make multiple long distance trips in order to obtain essential health care. After the 15-week ban was passed, my colleagues and I conducted a study to look at what access is like in Mississippi at the moment and before this law were to go into effect. So we obtained records of people who had obtained abortion in Mississippi as well as surrounding states in 2018, of which there were nearly 4,500 Mississippi resident abortions. And just to give you a sense of who in Mississippi obtains abortion care, 73% of patients were Black, 2/3 were between 18 and 29 years of age, so very consistent with national data. More than a third lived in counties with moderate or high levels of economic deprivation. Notably, Mississippi is the poorest state in the United States. And so these counties have very high levels of poverty and many other socioeconomic disadvantages. And of the 4,500 Mississippi resident abortions, 60% of those abortions were performed in Mississippi. And of the other 40%, 20% were in Tennessee, 15% in Alabama, and 5% in Louisiana. We also found that 17% of Mississippi residents obtained abortion care at 12 weeks from their last menstrual period or later. And this is greater than what we observe at the national level. And notably, 4% of abortions were performed at 16 weeks or more, which is the limit at the Jackson facility. So most of these folks were going out of state. Abortions at 12 weeks or later were more common among people who were less than 18 years of age and also lived in counties with moderate or high levels of socioeconomic deprivation. I also want to state that abortions later were less common among women who were white than women who were Black. And while many Mississippi residents getting abortion care have considerable travel burdens, and more women in Mississippi travel 50 miles or more to obtain abortion care than we see nationally, the travel burdens were greater for people needing abortion care at 16 weeks or later. They traveled twice as far to the clinic where they received care. And for most people needing care later in pregnancy, only 1 in 5 were able to obtain care at the facility that was closest to them. And more women who were 16 weeks or more traveled 100 miles beyond their nearest facility to get care versus just 5% of those who were less than 16 weeks, excuse me. So this really demonstrates how limited access to care is, particularly later in pregnancy for Mississippi already. And this could be even worse if the Dobbs decision is decided in favor of the state of Mississippi. We also did a survey of patients obtaining abortion care at the facility in Jackson in 2019. And of the more than 200 patients that we surveyed, we found that most patients did not return for their abortion visit the next day. And about a third had a week or more in between their mandatory consultation visit and their abortion visit. And so oftentimes, as we've seen, these mandatory waiting periods usually end up taking longer for people to be able to return for care. And this is for a variety of reasons. Patients oftentimes have to make multiple arrangements to get to the clinic, including missing work, which can result in lost wages. And for folks in Mississippi, half of our sample was already living on incomes that were less than the federal poverty level. So this can create incredible hardships. They're traveling long distances, as I indicated, and also are having to make arrangements for childcare and elder care responsibilities. To pay for their abortion, which I noted is not covered by commercial insurance plans or Medicaid, about half of the people surveyed said they had to delay at least one routine expense or sell something of value. This included a third who reported delaying paying utilities, 20% who reported putting off car expenses, 13% their rent or mortgage, and 11% who put off buying food. 42% obtained financial assistance from others, including the man involved in the pregnancy, friends, family, and abortion funds. And more than half of the people surveyed said it was somewhat or very difficult to pay for their abortion. And overall, we found that the vast majority of patients surveyed, 87%, experienced at least one economic or logistic hardship to obtain their abortion, and over a third reported 3 or more hardships. And all of this is on top of the close encounters that patients continue to endure with anti-abortion protesters outside of the facility. Following our survey, as we were doing follow-up interviews with women, the city of Jackson passed a buffer, bubble zone, and quiet zone that was immediately challenged. But we were able to interview participants in our survey about their experiences with protesters. And you can see here by some of these quotes that it really creates an environment of intimidation around the clinic. Protesters are able to get very close, approaching people in their cars. They follow them down the street. They follow them to their cars when they return after their appointments, and they're very persistent in attempting to contact patients and pass out materials. Unfortunately, the city of Jackson ended up repealing its buffer and bubble zone because it was unable to continue the the legal fight around this case. So I'm going to turn now to work that my colleagues and I have done in Texas as part of the Texas Policy Evaluation Project, and specifically assessing the impact of SB 8 on the ground. So Texas is a very big state, much bigger than Mississippi, but there are still considerable travel burdens for people needing care. As Anjali mentioned, and as folks probably know, SB 8 limits abortions in Texas or they're prohibited after embryonic cardiac activity can be detected, which is about 6 weeks. So folks who remain eligible for care in Texas still have to travel quite far to get to a facility. The facilities in Texas are primarily located in the major metropolitan areas: Dallas, Fort Worth, Houston, Austin, San Antonio. And so as you can see in the image on the left, people who live in the Texas Panhandle and West Texas, counties that are shaded in darker colors of blue, live 100 miles or more from the nearest facility. So they already have a considerable travel burden. For folks who are past the limit, current limit in Texas, and who have to travel out of state, as you can see in the map on the right, they have enormous travel burdens. More than 90% of Texas counties are more than 100 miles away from the nearest out-of-state facility, and about 3/4 or 200 miles away or more. And in the tip of South Texas, in the lower Rio Grande Valley, people are facing travel distances of about 800 miles to get to the nearest out-of-state facility. So using data that my colleagues and I had collected with abortion patients seeking care in Texas in 2018, we looked at the expected impact that the law would have on people's access to care. And we found that while over half of people contacted a clinic before they were 6 weeks into their pregnancy, just 16% were still less than 6 weeks by the time they attended their abortion appointment. So we were expecting the law to have an incredible impact on people's access to care and force many people to be ineligible. And we did find that the law had a very substantial impact on people's ability to get care. Using data that we collect on a monthly basis from the majority of large volume facilities in Texas, we found that the number of abortions decreased by 50% in the first 30 days that SB 8 was in effect. So comparing September 2021 to September 2020. This decrease is larger than the 13% decline we documented when about half of Texas's abortion facilities closed following implementation of House Bill 2 in November 2013. And it's larger than the 38% decrease we documented following the March 2020 executive order prohibiting most abortions at the onset of the coronavirus pandemic. The decrease in Texas probably was not as large as we might have expected, although 50% is still huge. But I think that there are a variety of reasons for this. One, the period leading up to implementation of SB 8 allowed clinics to prepare and create protocols on how they were going to see and care for the maximum number of patients that they could. With fewer patients seeking care at the facilities, but clinics remaining continuing to have the same staffing level and operating hours that allowed them to see as many patients as possible. Patients also prioritized obtaining abortion care over other responsibilities. So whereas before they may have waited to come back for their abortion when they had their next day off of work, a wait like that would have made them ineligible for care. And there are also considerable financial donations made to help offset the cost barriers that many patients face and that contribute to them delaying care. So we think this is why we are seeing the type of decrease that we did. My colleagues and I are also have other projects underway to look at the impact of the law We are collecting data on the number of abortions obtained by Texas residents in neighbor and near neighbor states. We're also conducting in-depth interviews with Texans who obtained care out of state. And we're doing an online prospective survey of Texas seeking abortion care since SB 8 went into effect. So while we don't have a lot of this data all the way in or fully analyzed, I did want to share a little bit of a preview of the types of things that we might expect and some of the things that we're already seeing. So when Texas has enacted other restrictions, we have seen increases in people going out of state for care. So with the implementation of HB2, where about half of the facilities in the state closed, we documented an increase, about doubling of the monthly number of Texans who were traveling out of state for care in 2014 and 2016 compared to 2012 and 2013. And then this decreased slightly with the Supreme Court decision in the Whole Woman's Health case, but still numerous Texans were traveling out of state for care because many facilities in West Texas had closed. When Texas implemented or passed the executive order following the onset of the coronavirus pandemic, we saw the number of Texans going out of state in a 30-day period skyrocket. Nearly 950 people obtained their abortions out of state during the time when the executive order was in effect. And we saw that people fanned out all across Texas and to many states. Most people traveled from the major metropolitan areas of Texas and went to New Mexico, Kansas, and Colorado, were the top states where patients obtained care. And as you can see here on this map, in South Texas, we did not find many people who had traveled out of state. And I think this gives us an indication that people living in this area just face incredible travel burdens that overlap with the difficulties they may have crossing interior border checkpoints around those areas that may make it impossible for them to travel out of state for care. And they may either obtain pills in Mexico to end their pregnancy or be forced to continue their pregnancy. And while we don't have the data in from what has happened since SB 8, we are observing increased wait times at facilities in neighboring states, which suggests that they are seeing a surge of patients from Texas. Appointments in September 2021 were longer in most cases, and those are represented by the blue dots, than July 2020, which is the most recent data that we had to compare. And wait times exceeding 2 weeks were common at many locations. And this may push pregnant people beyond the gestational limit for medication abortion or into the second trimester of pregnancy. As I mentioned, we're also doing interviews with people who have obtained care out of state. And while we haven't done a comprehensive analysis of those interviews yet, I did want to share a couple of quotations from what we're hearing from the people that we are talking to. We're hearing stories like this one from a 23-year-old Latina woman who traveled to New Mexico to get her abortion. She was seemingly eligible for care when she presented at a Texas clinic, but when she returned the next day, there was embryonic cardiac activity that was detected and she was no longer eligible. And so she faced a 14-hour drive one way to get her abortion in New Mexico. And we're also hearing stories like this one from a 41-year-old woman who traveled ultimately to Louisiana, who did not even think she was as far along as she was in her pregnancy, but still, well within the gestational limit for most states. And when she found out at her ultrasound visit that she was not going to be able to get an abortion in Texas, she considered going to Florida, Mississippi, Oklahoma, and called multiple clinics, including several in Louisiana, which is ultimately where she obtained care. So I'll leave it there and take any questions that folks may have. You can find our contact information and social media here.
Perfect. Thank you so much, Carrie, for that presentation. I think we have, let's see here, a question in the chat. Let's see, Carrie, how will states monitor telehealth for medication abortion provided by an out-of-state provider? And what about out of country? For example, Canada, Europe.
Yeah, that's a great question. You know, there are other folks who are looking at some of the, speaking first to the out of country, perhaps, other folks, Dr. Abigail Aiken, who has for several years been looking at services provided through Aid Access, and has, I think, will be able to show down the road kind of what the impact of SB 8 has been on requests for medications through that service. One of the things that complicates or makes the current situation even worse is that last week, Texas implemented Senate Bill 4, which placed numerous restrictions around medication abortion, one of which is prohibiting the provision of medications through mail. This is on top of a telemedicine ban that's already in place. So technically, according to SB 4, it is not legal for people to mail medications to residents of Texas. And so that really constrains access to that method for people who might be interested in it. And to the point about Mexico's abortion policies, my understanding of Mexico's Supreme Court ruling is that the change really needs to occur on a state-by-state basis. It's not necessarily a decision that had an immediate effect nationwide. So the states bordering Texas, I have not heard anything yet about changes in the criminalization policies in states that immediately border Texas, but those likely will be forthcoming. Whether or not there are providers who are able to serve the number of people who might be needing care, I think is another question that will take some time to answer.
Perfect. And another question in the chat, how did you get the women to participate in this survey? And then how are you all approaching reaching out to these women?
So for the in-depth interviews, we are putting flyers at clinics at independent clinics in the neighboring states, which account for the majority of the facilities in those states. And we have, talked with staff about making those available in places that would be easy for patients to find them. We've heard from the people that we've talked to that in some places, staff are encouraging them to speak out about their experiences and share their stories with us. And we've also just, people are really upset and really angry, and they really want to share their experiences. And so we actually have not had too many difficulties getting people to participate in the interviews. And we are doing those interviews by phone.
Perfect. And then Kay shared a resource in the chat for anyone that wants to check that out. The other question, have you thought about replicating the Texas analyses for Mississippi?
On which, I guess I'm not clear which aspects of the analyses.
Lauren, do you want to add to that in the chat or perhaps come off of mute? She will add it in the chat, so we will stay tuned. And any other questions, feel free to chat them in. Or you can feel free to come off of mute if you would like to ask a question. I apologize if you already touched on this because I joined a little late. Could you share how or why you chose the states that you did for your research? Do you have any plans to expand your research to other states, such as Missouri, that are facing restrictive policies on abortion?
Sure. So the Texas Policy Evaluation Project has been around for about 10 years. And so we have been doing this work looking at the impact of changes in policies related to family planning, contraceptive policies and funding and abortion for that time. And so this is just a continuation of that work. And regarding the work in Mississippi, prior to joining the faculty at UT Austin, I was at the School of Public Health at the University of Alabama at Birmingham and doing research down there, got connected with the medical director of Jackson Women's. And so we have done several projects together over the last 4 or 5 years. I do believe that there are some folks who are doing work in Missouri as well as other restrictive states, Georgia, Ohio, Wisconsin. So there are more folks who are doing this kind of work.
Thank you, Kari. Okay, any last minute questions? Feel free to get them in the chat before we move on to our next presentation.
And I can just respond. I am going to have to hop off, but I'm happy to respond to Lauren's question following the session today by email, Reagan. So if you want to just share that with me, that would be great.
Perfect. Thank you so much, Kari, for your presentation. And I will let everyone know they can connect with you after if they have any lingering questions.
Great. Thank you so much.
Okay, and I will go ahead and hand it over to our next presenter. Thank you, everyone, for all the wonderful questions.
Hi, everyone. Thanks for having me at this session. My name is Greene Foster, and I led the Turnaway Study. And unfortunately, this study is going to tell us a lot about what the impact of the restrictions that were just described by my previous colleagues. So the Turnaway Study aimed to describe the mental health, physical health, and socioeconomic consequences of receiving an abortion compared to carrying an unwanted pregnancy to term. And the idea at the time was to understand the consequences of abortion, but given the restrictions that are being passed, the consequences for people who are carrying an unwanted pregnancy to term are likely to become much more relevant because many people will not be able to access abortion. As Dr. White showed, abortions in Texas went down by 50%. So this study is a collaboration of a large number of scientists and from many institutions, but mostly the University of California, San Francisco. We recruited 3 types of women, people who were just a few weeks too late in pregnancy to get an abortion, people who were just under the limit and got an abortion, and people who were in the first trimester from 30 abortion facilities across the country. We excluded people who were seeking abortion for fetal anomaly or maternal life indications. And in 2007, when I started it, I mistakenly said the eligibility was pregnant women. And so we don't have any trans men or non-binary people in the study. And so I will refer to the people in the study as women, but people who are not women sometimes seek abortion care too. We interviewed almost 1,000 women between 2008 and 2018. We followed women for up to 5 years using semi-annual interviews in English and Spanish, and then we did in-depth interviews with 31 women. So just a few quotes to start with. This is to demonstrate that people, when they're making the decision to have an abortion, are understanding their consequences, understanding their choices, trying to weigh their circumstances and make the decision that's best for themselves. So a 24-year-old woman from New York who was denied an abortion said, it's very, very difficult to find a job when you're pregnant, to keep a job when you're pregnant, or to find and maintain a job with your baby, especially if your partner doesn't want to help. So domestic violence skyrockets because you're financially dependent on your partner because you have to be home with the kid. Pregnancy is an incredibly scary thing if you cannot trust the person you're with. And another person in the study reported the first woman that I said from New York was denied the abortion. This woman received her abortion and had another child within the 5-year study period. So she's comparing what it would have been like if she hadn't received that abortion in the study compared to having the child that she did have subsequently. She says it probably would have been the worst thing for that child to come in this world because it would have never had the support it needed. I wasn't mentally stable for that child. I do have a 1-year-old now, and I'm able to support myself, able to support my kids, and know the timing is right. So let's talk, so now those few quotes, but let's talk about what the quantitative findings of the study are. We find that denying people abortions is more harmful, at least initially, than allowing her to get one. We find greater anxiety and lower self-esteem among people who are denied abortions compared to those who receive it. But in the long run, the mental health of people who received an abortion and those who were denied were the same. So there isn't a major mental health consequence of receiving an abortion or being denied an abortion. And it's not because both groups are doing terribly. In fact, both groups improve over time. So there are many states that have policies that mandate that women be counseled on the negative mental health harms from abortion, and those are not based in evidence. There's not evidence that those are reasonable warnings that people be given. Just even though abortion might not cause mental health problems, we still wanted to look at the emotional consequences of receiving or being denied an abortion. Here's the most famous statistic from the Turnaway Study, is that more than 95% of people who received an abortion said it was the right decision for them. Positive emotions like relief are more common than negative ones like sadness, anger, or guilt. About 4 in 10 women have some negative emotions, but even among the people with negative emotions, over 90% say that abortion was the right decision. So you can feel sad, but it doesn't mean that you made the wrong choice. When we look at people who are denied the abortions, initially 2/3 of people say they still want to get an abortion, but after the birth of the child, that goes down to just 12%. It is less common among the small fraction of people who choose to place a child for adoption. And I know Coney Barrett and the Supreme Court said that adoption was the solution to abortion and unwanted pregnancy. And this study shows that people who are denied abortions do not choose. The vast majority choose to raise their child. They do not choose to place a child for adoption. And when people do place a child for adoption, they experience more regret and difficulty than people who choose to parent the child. But there aren't huge differences in mental health between those who received and those who are denied an abortion, but there are very large differences in physical health. I think people vastly underestimate the risks of childbirth and continuing pregnancy into the 3rd trimester. What we find is that women who carried the pregnancy to term were much more likely to have a life-threatening complication from birth. We find worse physical health and among the people who delivered, and it lasts for years. We found greater hypertension, several types of chronic pain that were higher among people who were denied abortions. And women who were denied abortions were more likely to report that they were in poor or fair health than women who received abortions. And the saddest finding is that 2 women who were denied abortions actually died from childbirth. They died from childbirth-related causes. We had no deaths among people who received their abortions. So it highlights the fact that carrying a pregnancy to term is a much more serious physical risk than having an abortion. And I think that if these laws, are allowed to stand that further limit abortion, we're going to see an increase in maternal mortality. This is not doing justice to the rest of our findings, but quickly to describe some of the differences in other life outcomes. When we compare people who received an abortion to people who are denied an abortion, women who are denied an abortion are more likely to live below the federal poverty level, to report that they don't have enough money for basic living needs, more likely to be evicted, more likely to declare bankruptcy, have a larger quantity of debt. They're less able to provide for existing children. We see that in the chance that their existing children are being raised in poverty, and also their children's ability to achieve developmental milestones. They're less likely to have an intended pregnancy in the next 5 years. I feel like this is super important for people who think that restricting access to abortion is entirely pro-choice, pro-life. We find that women are more likely to have intended pregnancies if they receive their abortion. So many people who have abortions say they want to have children in the future. They just want to have them in better circumstances. And we find that women are more likely to have that intended pregnancy if they're able to terminate an unwanted pregnancy. They're equally likely to be in a romantic relationship with the man involved in the pregnancy, although that's very low. The relationships of the man involved dissolve pretty rapidly over time, which is not surprising because many times that's the reason people give for wanting to have an abortion. But they're less likely to be in what they call a very good, to rate that romantic relationship as very good. And then sadly, we also ask them what their plans are for the coming year and the coming 5 years, and we see they're less likely to set aspirational plans if they're denied an abortion than if they receive one. Just a graph on these life outcomes. This is the chance that the household is living in poverty over the 5 years. So the Turnaway Study demonstrates the importance of access to abortion on a range of outcomes, their physical health, the well-being of their family, and the trajectory of their lives. We find that abortion is associated with better physical health, financial security, aspirational plans, and the ability to take care of existing and future children. So the question is, could we have foreseen these results? Well, at the very beginning of the study, we asked people what their reasons were for wanting to have an abortion. And we didn't give them a list of acceptable answers. We just let them answer in their own words what they were thinking, why they were making this decision. And then we categorized their answers. And we find our data exactly matched like the Guttmacher's data that are a national sample of people getting abortions in clinics. And the most common reasons are financial. And we see that they're right to be concerned because people who are denied abortions are more likely to be poor. They say it's not the right time for a baby. And we see that people are more likely to feel a close connection to their child born from a subsequent pregnancy than they are to this child. They give partner-related reasons, and we see that partners' relationship with the man involved in the pregnancies dissolve regardless of whether they receive their abortion or not. They say they want to focus on their existing children, and we see a difference in the chance that their existing children are living in poverty and achieving developmental milestones. So I could keep going, but what this tells me is that people, when they're making the decision about what to do with an unwanted pregnancy, they're making decisions that are right for themselves and their family. You know, no one ever knows what happens on the route they don't take. You know, if you opt for an abortion and you can't get one, we can see that that their outcomes are worse than among the people who were able to receive their wanted abortions. So these restrictions that will limit people's ability to end pregnancies that they aren't ready for will make their lives harder. Just in 2020, we published a book about the Turnaway Study. It presents the the background and the science of the study, why this is a difficult question to answer, how we answered it, the science findings, but interspersed with the science are the stories from 10 women in the study told in their own words about how it was that they decided to have an abortion, how they maybe were delayed by not realizing they were pregnant, and then what the consequences were for them of either receiving an abortion or being denied an abortion. Please feel free to contact me later if you have questions that you're unable to get answered in the chat. Thank you so much.
Thank you so much, Diana, for that excellent presentation. I was not aware there was a book, so that's very exciting. I can't wait to dive into that over the holidays. So if you have any questions for Diana, please feel free to chat them in now, and we will get to them at the end of our final presentation. So I will hand it over to our final presenter. Thank you.
Sorry, I was having trouble finding the unmute button once I was presenting. Can you all hear me?
Yes, you sound perfect.
Great. So I'm here to talk through the implications of abortion restrictions in the United States and the landscape that Anjali talked about, the studies that Kari presented, the Turnaway Study especially that Diana presented, and I'm going to try and take all of that. Sorry, there's someone ringing my doorbell. Give me 1 second. So sorry about that. It's the joys of working from home. So I'm going to hopefully try and move us into more of a space where we're talking about the more general health outcomes and maternal and child health outcomes based on the abortion restrictions that we're seeing kind of crop up throughout the United States. So I do want to first start by saying abortion is essential health care. This term really came up during the COVID-19 crisis, but it remains true whether we're in an emergency pandemic or not. An essential service means that this service is vital to the health and welfare of the population at hand. It's critical that that service is maintained and that the service is absolutely necessary and time dependent. Defining abortion as an essential healthcare service really helps us create kind of a true and broad understanding of the fact that abortion is a social good. It is not just healthcare, it is not just essential, it is critical to the health of women and families. So I would kind of be remiss if I didn't at least start with saying the public health, outline of abortion restrictions is that they will most harm these populations that you see on the screen. They will most harm Black people, Indigenous people, low-income people, young people, people living in rural areas, people of color, and queer people. As Anjali said at the beginning of her presentation, we want to acknowledge that abortion is not something that only affects women. It also affects non-binary people, trans men, and families. So here I have people across the board because, as you'll see throughout my presentation, what we're really talking about is the fact that restricting abortion or making abortion difficult to access or impossible to access really has a wraparound effect on an entire community. So one of the studies that I want to point everyone to is a 2014 study from IBIS Reproductive Health and the Center for Reproductive Rights. This study basically found that there is an adverse relationship between a state's number of abortion restrictions and a state's number of evidence-based supportive policies for women and families. So two global truths that we know about public health in any community is one, that timely access to care across health needs is critical to good health and well-being. That timely piece is really, really critical when it comes to abortion and abortion legislation, because as Anjali gave an overview of, gestational bans are really the most common type of ban in the United States when it comes to abortion. The second global truth is that structural racism contributes immensely to poor health outcomes for Black people, Indigenous people, and other people of color. So holding these two global truths,
Simon?
the IBIS Reproductive Health and Center for Reproductive Rights study from 2014 basically found a way to score states on the number of abortion restrictions they have, as well as a score for the top 4 topic areas of women's and children's health. So what you see here is that line is trending downward. The more abortion restrictions the state has, the less likely women and children are to be healthy, have good health, have strong, good well-being. I'm going to touch quickly on maternal health. Again, the Turnaway Study is an excellent, excellent resource for information. I'm staring at Diana, knowing that the Turnaway Study is something that I have read so many times myself and that I really, really value. So I'm going to give a really brief overview here of maternal health and child health. First, maternal health. Carrying a pregnancy is high risk. It is more dangerous than getting an abortion, including later abortion. So from gestational diabetes to preeclampsia to postpartum complications, a pregnant person will face any number of, really poor health outcomes for carrying a pregnancy to term. These, while they may not be exacerbated necessarily by being denied an abortion, they are absolutely risks that someone does not need to face should they choose to not carry a pregnancy to term. Abortion restrictions end up creating an environment of forced pregnancy. And again, pregnancy is high risk. Secondly, in states where there are really heavy abortion restrictions, people who are seeking an abortion, may wait until the very last minute to really accept that that won't be possible for them based on any number of restrictions. This could lead to delayed access to prenatal care. If you are seeking an abortion and you're trying your best and you can't make it happen because of any number of factors that are outside of your control, you won't seek prenatal care. And when you do finally seek it, it will be delayed. Lastly, the economic burden of either having to travel really far, as you saw in Kari's study, to obtain an abortion, or of forced pregnancy itself and forced birth itself will negatively impact long-term health outcomes. As Diana said, and as the Turnaway Study says, states with more abortion restrictions tend to have worse maternal mortality rates. They tend to have worse infant mortality rates as well. Carrying a pregnancy to term creates an entire area of financial burden on a family or on a person that they did not want, were not expecting, and did not plan for. Unintended pregnancy creates unintended economic burden. Next, again, really quickly on child health. Basically, what we know to be true is that early life experiences shape lifetime health outcomes. And the early life experiences of a baby born through an unwanted pregnancy, a forced pregnancy, or a forced birth are poorer than the early life experiences of a child born, from a wanted pregnancy that was carried to term. First, I want to highlight that the lack of reciprocal investment in early childhood health care in states with abortion restrictions is a huge problem. As other folks on this presentation have said, states, the most common thing that people say about people who are pushing abortion restrictions is that they are quote unquote pro-life. We can see from, analyses of state policies that in fact, they are pro-birth. States with really, really extreme abortion restrictions do not have, the next step of really, really adequate or expansive investments in things that would help create an early childhood full of health and well-being and good outcomes. Secondly, as I said before, financial strain really affects the economic health of a family. When an unintended pregnancy is forced to be carried to term, the financial strain that creates may perpetuate cycles of poverty. It may keep children from getting an education. It may keep children from really accessing all of the things they need to have a full life, the full life that we should all want. Lastly, studies do show a measurable difference in maternal bonding and reaching developmental milestones for children who are born to folks who are seeking an abortion and were not able to obtain it. The fact of the matter is, an unintended or unwanted pregnancy that is forced to be carried to term will make a difference in the way mama bonds with baby. We know from decades and decades of research that maternal bonding is key in early childhood development. That means that a lack of maternal bonding or, slipshod maternal bonding may create a situation where a child is not able to reach, the regular developmental milestones that a pediatrician checks for. Next, I want to talk about the ripple effects of being unable to obtain an abortion and being forced to give birth or forced to carry a pregnancy to term. First, motherhood wage penalties and a lack of paid family leave policies. So a number of studies have been done on motherhood wage penalties, but the long and short of it is that in many industries, we see that people who do choose to become mothers or are forced to become mothers face differential, outcomes when it comes to being promoted or getting raises, getting bonuses, because they're being essentially penalized for having a child, for having their interests split between home and work. Motherhood wage penalties, when they're levied against people who had to carry an unintended pregnancy to term, can be particularly devastating. In the news lately, we've all been hearing a lot about paid family leave. I think all of us have seen that map where we are the only developed country without federal paid family leave policies. And that lack of policy, that lack of infrastructure to take care of families really does exorbitantly impact families who had to be created because of abortion restrictions, people who were forced to carry an unintended pregnancy to term. These lack of paid family leave policies affect all families across America, and especially families who did not expect to have the economic burden of a child. Secondly, education opportunities for mother and child are affected. As I said before, young people are particularly impacted by abortion restrictions, and young people who are not able to obtain an abortion may have to drop out of school. They may have to, take away time from what would have been their life so that they can figure out what they need to do if they're unable to obtain an abortion. When the child is born, when the baby is born, cycles of poverty, cycles of abuse can be perpetuated because being unable to obtain an abortion can keep someone in a situation that they would have otherwise left, that they would have otherwise been able to save up money for and leave. So the ripple effects of being unable to obtain an abortion are really, really broad. They affect more than just the mother. They affect entire families and sometimes generations of families. Next, I want to talk about self-managed abortion. So what we're seeing across the states, as Anjali said, is really, really draconian abortion restrictions being levied, and unfortunately with the makeup of both lower and the Supreme Courts, we're seeing that they're kind of passing through without any stop. And now with Dobbs, we are in a really, really scary situation. So these maps from the Kaiser Family Foundation show both where self-managed abortion laws mean that self-managed abortion can be criminalized, and where self-managed abortion has prompted arrests and criminal investigations. So for centuries, women have turned to self-managed abortion, both during periods of legality and illegality. Loretta Ross, who founded the reproductive justice movement in America, has often said that people have been seeking self-managed abortion, not only because of abortion restrictions, but also because of logistical accessibility problems, financial barriers, cultural barriers, or because they don't want to engage with the formal medical system, which is a system that is rooted in institutional racism. As the numbers of state-level abortion restrictions continue to skyrocket, clinics are closing, women are struggling to afford abortion, and women may turn to self-managed abortion. Self-managed abortion is safe. There is a brand new study out telling us how safe it is. It's called the SAFE Study to really drive the point home, and it's from IBIS Reproductive Health. And we do know that self-managed abortion at home is safe. However, as these maps show, it is also very criminalized. And that criminalization is a huge public health emergency, because as Dobbs gets decided, as more and more folks start to seek self-managed abortion care by pills through the mail or otherwise, you know, something that they do have to consider is the threat of criminalization. So mass incarceration and criminalization are public health emergencies, and they affect the general health and well-being of entire communities. Miscarriages, both in the news and in the law, can be conflated with induced abortions, especially when the pregnant person is a person who uses drugs or they have used other substances, including legal substances, to self-manage their abortion. Many medical and legal organizations oppose the criminalization of substance use during pregnancy because they know that all it does is put people in more and more harmful positions and in more and more harmful situations. Criminalizing pregnancy, criminalizing the pregnant body, and criminalizing pregnant people creates entire swaths of the community who cannot live safely in their home, who cannot continue to do what they need to do to take care of their family, and who will then be put into the mass incarceration system that we know is biased against Black people, Indigenous people, and other people of color. I wanted to make the specific point related to people who use drugs or substance use in pregnancy and criminalization, because this is kind of the blueprint for what we're about to face. Bias, judgment, and stigma keep people who use drugs from seeking prenatal care and other necessary medical care during pregnancy. As abortion becomes less and less accessible, as the Supreme Court makes the decision we think they're going to make on Dobbs, we have to consider how the same bias, judgment, and stigma will keep all people from seeking prenatal care, will keep all people from seeking the necessary medical care during pregnancy. The treatment of people who use drugs who are pregnant can and really should be used to predict the treatment of all pregnant people when or if Roe is no longer law. You know, these laws are all tied up in systems that we know do not work. Systems like the foster care system, systems like really broad child abuse laws that apply to the pregnant person and to the fetus, creating fetal personhood, systems of incarceration, systems of criminalization, and systems of policing. So when we take a look at this map of many states criminalizing substance use in pregnancy, I think it's important for us to understand that criminalization is a public health emergency. And what we're facing down the road is mass criminalization of abortion. I did add in this toolkit from the Academy of Perinatal Harm Reduction called Pregnancy and Substance Use. I really urge folks to go and take a look at it. It is incredibly helpful in creating a framework in which we understand what criminalization can really do to pregnant people, to their health outcomes, and to the health outcomes of the people around them. And here are some of my sources. Thanks, everyone.
Okay, sorry about that. I was like, where did my screen go? Thank you so much for that excellent presentation. I think especially what resonated with me was that last point and how important that is for people to start to think about. So what I'm going to go ahead and do is open up the floor for questions for our speakers. So feel free to chat in, and there are a few questions. So let's see here. We had a question around, can you describe what you include in the category of self-managed abortion? And all speakers can kind of feel free to chime in on this as well.
I can start. Anjali or Diana, obviously feel free to jump in. I would say that the category of self-managed abortion includes, but is not limited to, people who manage their abortion at home using pills, which they obtain either from a clinic or through the mail. But I think broader than that, we can include in self-managed abortion people who use things other than pills that they are comfortable with using. But when we talk about the safe study, or when we talk about what we've studied as, self-managed abortion is safe at home, the things that have been studied are pills, are medication abortion.
Perfect, thank you. Where can we get access to the harm reduction toolkit?
I can drop a link in the chat and send it to Reagan.
Perfect, and I'll get that added in the conference platform under this session. Okay, I'm scrolling. Is there an age limit, specifically the youngest age for a woman to get an abortion?
I can answer that. These restrictions are often framed not in terms of what's the youngest, but saying that anyone who is a minor needs parental consent. So the way that those laws generally work, and the majority of states have them, is that the default is that you need parental consent to get an abortion. If you can't get that for whatever reason, then you have to go through a procedure called judicial bypass, which is that a minor has to file a petition and appear before a court and establish that they are mature and well enough informed to make the decision for themselves. So these judicial bypass laws, in many cases, are pretty difficult. There's just, obviously the logistical mechanics of filing the court paperwork, but then often, of course, these are folks who have never, appeared before a court before. They're being asked questions, by a judge. States have in place usually that the minor needs a guardian and or an attorney ad litem present at the hearing. It's a pretty onerous process, especially laid on top of all of the other restrictions that make it more difficult for people to access care, such as waiting periods and things like that.
Thanks for that answer. And the ironic part about all of that is deciding that someone may not be mature enough to get an abortion, but we're going to make them have a child. So. Okay, the next one, and I would love to hear all the speakers' thoughts on this. Could you speak on why people do not view abortions as essential healthcare? Diana, would you want to kick us off on that?
That's tricky, being asked what people think who don't agree with me. Can I try and get Anjali or Arpita to answer it first?
Yeah, I can certainly jump into the lion's mouth here a little bit. I think part of it is, as Anjali kind of stated in her presentation, kind of dogmatic political reasons, right? There are folks who will refuse to see abortion as even healthcare because of their political or religious beliefs. And unfortunately, those religious beliefs have turned political and have become a really big part of the political sphere. I think also during the COVID-19 pandemic, people really bastardized the meaning of an essential health service and kind of refused to see the very basic things, right? That those of us on the call see as essential, that abortion is time sensitive, that abortion is necessary, that abortion is part of women's health care. So I think it's what Diana was saying, right? These are people who don't agree with me. So I guess I'm speculating, but I do think there's something to be said for the dogma.
I think there's also an element where, I think people, and particularly like anti-abortion politicians, like to frame abortion as a thing apart. But the fact is that abortion is just part of the spectrum of reproductive health care in general. And I think reproductive health care in general is not always treated well by, policy, by politicians. Arpita talked about a lot of that when she was talking about paid parental leave, or even just pregnancy complications from people who are carrying wanted pregnancies. I think there's a general lack of respect, honestly, for the importance of reproductive health care, and that includes abortion.
Perfect. Thank you for your responses. We have lots of questions coming in. So let's see. Have any of these studies looked at the implications that abortion limitations have on the disabled community?
I can say that that's an area that's definitely lacking, at least from my understanding. The implications on people who are disabled are both unique and similar to the implications we know on the general population. But I'll say that I know of disability advocates who are working on that space of intersection, and I hope to see more of it.
Perfect, thank you. And Diana, we have one for you. Magda says, great work. The Turnaway Study is a landmark. Can you speak more to the relationship between housing security and eviction and abortion turnaway?
Yeah, I can. And I can even very quickly do the other couple questions that came in. I was asked whether we looked at undocumented people, and 8% of the people in the Turnaway Study were immigrants, but we didn't ask them their legal status, so I don't know. Krista asked whether there was an increase in unsafe abortions among people who were turned away, and this study was unique in having people pretty far along in pregnancy, and so ordering pills online was not an option. We didn't have anyone who went and did something terribly dangerous, but we did have a couple of people who claimed they miscarried afterwards, and although we asked what might have caused the miscarriage, they didn't say. So I don't know what people did, but we didn't have anyone have serious complications from trying to have an abortion outside of the medical system. And then the question that you actually asked maybe was about housing, or that was a different one that came in. Sorry, I'm losing track. So we asked people whether receiving or being denied an abortion affected their ability to cover their housing costs, and we found a decrease in ability to cover housing costs if they carried that pregnancy to term compared to being denied. But also an economist at the University of Michigan, Sarah Miller, took the Turnaway Study data and linked it to credit reports, which is like all Experian and all these credit agencies that keep track of your financial well-being. So she took Turnaway Study people, what we did together, linked them to credit report data, and the credit agency doesn't know whether you've been pregnant, and it doesn't know whether you've had a baby, but in the archive credit reports, you could see that public records for things like bankruptcies and evictions increased for the people who are denied abortions relative to the people who received it, even though they were the same for 3 years leading up to the pregnancy.
Thanks, Diana. So there are a number of questions that kind of feed off of each other. Kind of the general theme I'm seeing is, what role can public health professionals play in ensuring access to abortion for their constituents? So, people that live in states, the example given, like Arkansas, that may only have one clinic available for medical abortion, or a state that has really restrictive or harsh policies around abortion. What can public health professionals in those states be doing? Is it more advocacy, more data-driven studies? What role do they even play in helping their constituents maybe travel for abortion or find and refer to abortion clinics? So just overall, public health professionals that may live in these restrictive states, what can they be doing?
I don't know if it's directed at me, and I'm sure Anjali has a really good answer. I just would say that given how political and ideological this is, being able to say that no matter how you feel about the debate, that there are real public health consequences when people get their abortions and are not able to get their abortions. And so it is incumbent on a public health community, public health approach to make sure that people are able to get safe services regardless of what state they're in. That what state you're in shouldn't determine your ability to make this decision, because and no matter how you feel about the decision, the outcomes are better for the health-wise and economically for the people who are able to achieve their desires in terms of an unwanted pregnancy. That was my suggestion, but I think Anjali may have a stronger one even.
No, I mean, I was about to say something very similar to that, which is I think something that public health advocates can really do is get comfortable with talking about abortion and then linking it to your expertise. Because I think there's this real tendency to kind of shy away from talking about it, and that doesn't really help anyone. And so if you can then make that linkage that Diana was talking about and frame it in terms of the public health need, I think that can be really powerful. And in terms of helping with arrangements, Arpita already said this in the chat, but I think it's really important for people who want to help to connect with the folks who are already on the ground doing the work wherever you may be. So that's often your local abortion fund. They'll already be networked, they'll already have thought about the logistics, be familiar with the people who are particularly in need of help. They're going to have ideas. And so I think, far more than, I think just tapping into what's already there is the most powerful thing to do. And then I also saw the question about framing the importance of abortion access to those who are very against it. I think Diana touched on that. I think another thing that we've seen has been successful from some of the messaging research is to say, take away the question of whether it should be legal or not. Just think about if somebody in your life who you were close to were decided that they wanted an abortion, whether you agreed with them or not, how would you want them to be treated? Would you want them to have to jump through all of these medically unnecessary and sometimes traumatic hoops that really financially burden them? Or, even if you disagreed with them, like, would you want them to have a safe and healthy experience? And so I think it's, if you bring it back to people, and if you bring it back to, how are we treating people, that's something that's been shown to be more effective than framing it in terms of a political or religious debate.
And I'll just jump in and say that as a public health person, shout out to public health people, we love each other. I'll say that something that's really critical, especially in states that are facing, an onslaught of restrictions, especially post SB 8 in Texas, it is really helpful to have people testify against these bills when they do go to hearing. And I know that that can sound daunting. And, my email will be available to you through Reagan, but putting together testimony as a public health expert can be really, really helpful to advocates who are fighting against these bills every day and whose capacity is really low. Even if you just submit written testimony or if you go in person and testify during the hearing, having expert testimony from public health professionals who can say, denying people access to abortion has wraparound health effects, not only for the person who is pregnant, not only for the baby that, will be forced to be born, but also for their family and for their entire community, is a really, really critical point of engagement for public health people. So I'll shill for getting involved in that part of the bill process.
Perfect, thank you. And I will mention quickly, I know there was a lot of questions around as public health professionals, what can we do? I know a lot of you on the call are from local health departments. So I will mention that Answer also has done some work around that and do have some resources available for ways you can get involved in making sure abortion is available and accurate information is being represented. They have resources available for that. And I actually see Claudia is on the call today from Answer. And Claudia, if you would maybe want to throw any resources in the chat box, I think public health professionals and the health department reps would be very appreciative. So we have about a minute left, but I would love to hear any closing words from our speakers. I know things can feel very doomsday right now, but I think it's always important as a public health field to remain optimistic. We're the ones that can get the work done. So I would love to hear just any closing words from our speakers.
I'll go first so I don't have to go last. I really want to thank everyone for getting on this call today. I know it was a late breaking session, so I really appreciate the participation. Thank you to Reagan and to City Match for having us. And I think, I've seen a couple of things in the chat about maybe hope is lost, maybe, once Roe is overturned, that's the end. And I really want to urge that we don't have to think that way, and that tons of us are doing this work every day. Tons of people in the states and in cities are doing this work every day. And I really urge folks to connect with them. And I really especially urge public health folks to engage with some of the harder issues in abortion access and abortion care, engaging with what does access look like for people who use drugs? What does access look like for young people or people in rural areas, people in historically medically underserved communities? really engage public health. I really urge public health people to engage with those areas and think about how we can continue to use that as we face, the really, really deep and scary attacks. So thank you all so much.
And this isn't going to be nearly as inspiring as what Arpita just said, but I also want to re-highlight that, there are things you can do. I mentioned it when I was speaking earlier, and I'm putting it in the chat now. The link to our local reproductive freedom index contains policy ideas that can be helpful at the municipal level, because we know that whatever happens at the Supreme Court, people are going to continue to need abortions, and people are going to continue to get them. And so the question just becomes, how can we help those people, regardless of what the courts say, get the care that they need? And there are ways to do that. I think policy doesn't start or stop at the courts. It's people, and it's honestly it's policy wonks, right? It's people who work for state and local governments who are seeing actual impacts and can put in place, change, even an incremental change to make people's lives easier. So I really appreciate the opportunity to do this session.
Perfect. And it looks like Diana heeded her time.
I wanted Anjali to have the last word.
Yes. Okay. So thank you so much to all of our speakers. Again, they really came through on a short notice, and I am thrilled with the number of people we had in this session. It makes me so optimistic that we really are starting to integrate abortion into MCH. It's something I've been working so hard on the past few years. So I'm so happy to see so many of you on the session today. I have contact information for all the speakers. It also should be in the conference platform, but you can feel free to reach out to me if you have any lingering questions and want to be connected. A number of resources were also shared in the chat, but really looking forward to continued conversation. I'm hoping we can bring back all of these speakers for a City Match Learning Network webinar and provide an opportunity for more engagement and more opportunity to ask questions. So thank you so much to all of our speakers, and we look forward to seeing you all throughout the rest of conference. Thank you.